Okay, looks like we are ready to get started. Thanks so much to everyone for joining us. We are the American Indian and Alaska Native Behavioral Health webinar series. I'm Kate Trams, and today Sean Bear will be teaching on ethical considerations in substance abuse treatment of Native clients. If you were here with us last month, we had Bob Rarrett who spoke in detail about a lot of the ethical guidelines and some of the practices that have come up for him in his work as the administrator of a substance abuse treatment facility. And today, Sean Bear is going to be going into aspects of cultural understandings and sensitivities around this as it may pertain to different practices among Native people. So thanks so much for joining us, and we're looking forward to having him give his experience and to share expertise on that. This training series is brought to you by the National American Indian and Alaska Native Addiction Technology Transfer Center. We are part of the ATTC network, which also includes 10 regional centers and a network coordinating office. Our center is an ADAC certified educational provider, and we'd be happy to provide you with CEUs for a $15 fee. The CEU request form is available for download in the Files pod in the webinar screen, and we will also be sending this form in a follow-up email to all who attended. Immediately following today's webinar, you will be redirected to our GIPR evaluation. SAMHSA asks us to evaluate our events in order to provide improved performance assessment and accountability. This survey asks about your satisfaction with the event and will take less than 10 minutes to complete. We thank you in advance for helping us to improve our programs. You will be muted for the duration of this webinar, so please use the Q&A or chat pods to share your questions and comments, and we will address questions at appropriate points during the presentation. Just so you know, the Q&A pod, you can be anonymous. That way you can submit your question and not everyone sees your name and who's asking it. But if you type something into the chat pod, people will see who you are. Which is great because it also helps facilitate conversation, which we would love to have people participate in as well. Today's webinar is presented by Sean Bear. Sean has been working here at the National American Indian and Alaska Native ATTC for, I believe, 4 years now, and he has been working with Native Americans with substance use issues for many years. He is an Army veteran, and his passion to assist people in overcoming their substance use issues, as well as others, and to return to the spiritual ways of our ancestors, are what motivates him in his work. So I want to thank Sean for being with us today, and I'm going to pull up the PowerPoint and pass things over to him here. Thanks so much.
Hello, everyone. Again, my name is Sean Bear. I work for the National American Indian Alaska Native ATTC. I am actually from Iowa with the Meskwaki tribe in Tama, Iowa. I'm glad you could all be here. Okay, a little bit overview of the presentation is, last week we had done some things, I think, with Bob Rarrett, talking about the 42 CFR and ethics and some of the ethical considerations that come into play. So here we have the ATTC network, and you'll see that within the network that there is actually, it's placed in certain regions, but it doesn't necessarily reflect the IHS region. So sometimes an IHS region might be in a couple of these regions and vice versa. At this point, we are the only national focus area. There should be another one coming on shortly. Okay, a lot of times what we do, we start out with recognition of Dr. Dwayne Mackey. He's passed away. He's done a lot of work with natives, and there's many kind of information about him out there and how he began and started his work, which led to the Native American curriculum in South Dakota and Minnesota. Our mission is to serve as national subject experts and key resources on adoption of culturally legitimate and relevant addiction treatment recovery services. A lot of times what we do is to work with either native tribes or to work with those who work with natives, so they get a better understanding of how to work with natives themselves. So the goals with the National American Indian Alaska Native ATC is to advance the American Indian Alaska Native substance use disorder treatment field and enhancing communication and collaborations with stakeholders and organizations. We have people around the country that we use as consultants, or we have an advisory committee which hold natives from all over the country. Okay, so a little bit more about the goals is, so with workforce development, we have gone into communities to figure out what is the reasoning. Maybe natives are not going to those agencies, or how that they could work with the natives a little bit better. And a lot of times we speak to the workforce itself and also with the native communities, elders, medicine people, the community itself. A lot of times what happens is possibly that the professionals who want to work with the natives might need more cultural information to be able to help them do that. Okay, so the target population, of course, behavioral health
Your
workforce.
microphone has been turned on.
Some of this is also with, we have worked with some mental health, in people with primary care, nurses, doctors, even such as priest or ministers. So there's different kind of organizations that we also work with along the way. So we get into ethics and cultural considerations. So if you looked at before with the recent changes within the 42 CFR, it reflects a lot from the primary care and the behavioral health integration. When that came into play, they had some difficulty with those in sharing information. So that led to the changes within the CFR to be able to accommodate that. A lot of times, either federal agencies now or those who get federal monies for those do come into play. But remember, with many of the tribal agencies, they are federally funded, so they are still in effect with those. Okay, a little bit more about, so we look at evidence-based practices. Now, different tools, or diagnostic, things like the DSM-5, various treatment programs or treatments, the way they come about it, assessment tools, evidence-based practice have become very popular in cases, and sometimes they're mandatory. Many have been developed over time with research and studies. So remember, with the studies, when it comes to certain populations and whether something is actually evidence-based, a lot of times they go through kind of a strict format there to make sure that it works with that community. But there hasn't been very many that have been tested with Native Americans. So a lot of times these are based upon Euro-American philosophies and backgrounds. I know before, like with the MMPI, a lot of times all the natives had been scoring higher than everybody else on those. So sometimes the culture does come into play. So for example, looking at this is that so throughout this country, the larger population goes by what they call a nuclear family, being father, mother, dependent children. Well, with the Native American culture and some other cultures, is that they go by an intergenerational family system. They could have grandparents in the same hold, in the same household, grandchildren, um, even parents, grandparents, and so forth. Sometimes they might have cousins and nieces and nephews. I do say adopted family members, but adopted family members, in the way I plate this, is not the same way that many people like might go through some kind of adoption agency. That's a little bit different than with the natives, because the way that they handle culture sometimes is that when somebody passes away, part of this grieving process is also to adopt somebody that's closer to that age, um, that they be able to like take the place of that person within the family. So that helps with grief issues and things like that. That person actually is part of the family, just as any others would be. So looking at that also within treatment centers, it can cause a little bit of issues, because the way many places are kind of based upon, like ethics, 42 CFR, confidentiality, they're kind of based upon a Euro system, in a sense, a Euro American, where you can go to a treatment center and you might not know anybody within the treatment center. But within a Native American treatment center, you can go into a treatment center and you might know many people who are in there. So it adds a little bit of cultural factors in there and things that need to be taken into consideration. Okay. So this is part of many of the professional standards and people go by, doctors, psychiatrists, mental health people, substance abuse, whatever it might be, is that many of the professions have an obligation only to work within their areas of expertise. But when you bring culture into it, sometimes those things are not as specific as they probably could be. Now, there has been cases where natives have been diagnosed with mental health disorders from a Euro-American standpoint, but culturally it might be acceptable. For instance, if you're looking at the belief systems of the culture, there may be people who look at natives kind of strangely, like, oh, this person's a little, doesn't seem quite right, but really those are our belief systems. And many of the natives, when they're talking about religion itself, they don't always use the concept of religion, because our kind of livelihood, especially in the past and other generations before us, our culture was based around our belief system, around our spirituality. It wasn't the other way around. We didn't think of those over one day out of the week or a couple days out of the week. It was something who guided our lives every day. So when you're looking at cultural competence, you need to understand that cultural competence cannot be done within a few days of training. I mean, to be able to really be competent within a culture, you need to be able to live within that community for years. Looking at our Native American curriculum that we've specifically mostly done in South Dakota, is that throughout those 3 days of training, at the very end of it, it came very clear that it was only like taking a class, a 101 class, very basic information. Now, a lot of that was covering a lot of cultural things, but very basic things. Every one of these areas could go further into detail. I mean, it could definitely be a whole course within a college or university. I mean, looking at this, taking apart even further you have layers upon layers of this culture that goes into spiritual practices, which, in a sense, is not really covered there. Medicine practices, which is not really covered. When I say medicine, it's not like taking medication in a sense. It is like plants and stuff that go in there, herbs, but also medicine is incorporated with everything. So it's like even spiritual things, in a sense, are medicine. There are gifts that are unseen that are medicine. So it has many things to do beyond what maybe outside the culture may actually understand. Okay, so looking at ethical principles based upon, the American Psychological Association. Now, in they began to publish their first code of ethics in 1953. Later on in 1981, they added the principles of it. And later on, the code of conduct was published again in 1992. Now, right now, we have the current ethical principles of the psychologist code of conduct. Now, if this is still true, then it was effective around 2010. We would have to look further into if there is another one that has come out. So, remembering that the APA has been around for quite a while, so many of the ethical codes are based upon the APA codes that from different kind of fields that came later on. So the general principles, of course, are beneficence and non-maleficence, fidelity and responsibility, integrity, justice, respect for people's rights and dignity. We will go over about half of these. So, I mean, there's really not enough time to go through it, every one of them, and take it apart in a sense. Now, looking at, let me see, looking at culture earlier, is that the practice of one community can vary differently from another community, even within the native populations. So if you're looking at, in a sense, the eastern part of North Dakota and all the way across the United States to the east, down through Minnesota into Iowa and parts of Kansas and the northern east part of Kansas, and then across again. Many of those tribes are woodland tribes. So their belief systems, their culture, the way they practice things are going to be a little bit different. Now that also goes up into Canada. Now if we look at, in a sense, the Great Plains, many of their practices are very similar also to those in Montana, those in Wyoming, and a little bit down into Colorado and such, but also looking at other states like California. Now, many of the big larger cities where many natives may live have adopted much of the practice of the plains. So you're looking down at the Southwest, those things are a little bit different as well. Now, some may be similar, but if you look down a little bit more or further into it, it can be very different. Okay, so look at beneficence. So it's an action done for the benefit of others. Now, there are cases where these things need to be more like saintly, be able to do good all the time and go out of your way to do these things. But there's also another part of it is more to prevent or remove harms that might come about. So looking at that, you need to be able to help clients promote welfare, defending the rights of others. Okay, an example that would be first aid, CPR, So non-maleficence is kind of still in that same category. So many times it's to do no harm. Now, I really like that about do no harm because um, long ago, learning from elders and stuff like that. Now, they had said even further back, thousands of years ago, is that there was only one rule, and if you could live by that rule, you could follow. That would help guide your whole life. And that one rule was to do no harm. So in doing that, we refrain from providing effective treatments or ineffective treatments or acting with malice towards patients. Example of that would be stopping a medication that is known to be harmful, refusing to provide treatment that has been shown to be ineffective. So something to consider with that is with culture itself is there is considerable evidence that culture and context influences almost every aspect of the diagnostic and treatment process. So looking at natives, looking at that is that looking further is that culture, in a sense, is really looking at prevention because they kind of go hand in hand. With the native communities, culture is prevention. And that's what a lot of studies are starting to be able to find out. They're realizing that these things are entwined in it. So if we're looking at the medicine wheel, culture, in a sense, is, well, with the natives, is that the medicine wheel, looking at the four directions and stuff, it's recognized all across Indian country, but the way they use it is different. The way that it looks might be different. I'm not saying that everybody has the same medicine wheel and stuff like that, because that's not true. I mean, many of the colors are different, but also it's recognized. But each tribe may interpret or use those things a little bit differently. Now, from that medicine wheel itself, we're looking at a holistic model to guide your whole life. But also the medicine wheel is, in a sense, that walk in life, which can be broken apart, in a sense, and taken in different contexts. So if you have one with life, you have one with medicine, you have one with spirituality, you have one that, in a sense, of life itself. So depending upon how this is being used to be able to teach all them things about life, from birth to rebirth. Now, with many of the native communities, we don't really believe in a death. So really, it's really a rebirth. You pass here, but you're reborn on the other side, and vice versa. So looking at individualized treatment plan, I mean, that's can be very similar with the new changes, in a sense, with the 42 CFR, is that looking at that, you can't really have, in a sense, a check mark saying all these people must be on this and we can send to every one of them. Now, the only way you can do that is if they have a choice, saying, okay, I want this one spoken to, I don't want this one. So a lot of times they'll be able to have a choice, and that choice is not up to the treatment program. It's not up to whatever it might, different agencies. It is up to the client. That is their right. So looking at a systemized one-size-fits-all approach to interventions is contrary to practice because everything needs to be individualized. Now, looking at individual outcomes with many things with the evidence-based practices is very narrow, does not aid in reducing disparities in behavioral health services. this also cannot be achieved through evidence-based research process, because we're looking at the tribal communities, and not all tribal communities are the same. So looking at a study that might have been done with one tribe doesn't mean that it'll fit all other tribes, if that makes any sense. So a balance between culturally competent practice and interventions that are scientifically evident is especially challenging when delivering interventions to those of other than ethno-cultural groups such as natives. Now, many of the studies that we're looking at, if you're looking at evidence-based practices and you're going to work with natives, part of that is to actually look whether those studies have actually been studied with natives beforehand. And if you look at many of the programs where they might have said was evidence-based to place it within a tribe, sometimes they don't work. Well, if looking a little bit further into that, is that if they replace the program they may have already, then there's a little bit difficulty. Those who have been a little more successful are those who have not just taken this program, place it in, and put cultural elements into it, but use the program of culture that is already in place and add parts of the evidence-based practice to it. Okay, so looking at fidelity and responsibility. So psychologists, you remember now, and the way I say this, I'm not just talking about psychologists. Remember that many of these codes and stuff are based upon the APA. So they go into other ethics as well in other fields. So psychologists establish relationships of trust and are aware of their professional scientific responsibility to society and specific communities in which they work. So psychologists consult with, refer to, or cooperate with other professionals in institutions to extend what is needed to serve the best interests with whom they work. So if we were to break this down in a sense, now specific communities in which they work consult with or refer to or cooperate with other professionals to the extent needed to serve the best interests with whom they work. Now professionals. Now in a sense looking at that, it's of, relating to, or characteristic of a profession. The act of taking the vows of a religious community. A calling required specialized knowledge of long and intensive education. Now, looking at many of the native practices that have been going on for thousands of years, I mean, we, along with culture, language, the spiritual practice, the medicine practices, there isn't really we don't really get certificates. We don't get graduation things and stuff like that. I mean, it's something that takes time, but by the time that somebody has reached a certain level, then that is known by the community or those who are working in that same areas. So, looking in consideration of that is evidence-based practices is science based on observation to prove evidence. Experience-based practices, like the Native American culture, is native traditional practices and knowledge are based upon thousands of years of observation. That is evidence that it works. Thousands of years of observation. Now, science is based upon observation to prove evidence. So looking at that, traditional Native American practices, again, didn't have degrees, certificates, or licensures in the past. In some areas, they have begun to do this because people who have taken the practice learn some things from the natives and then begin to sell those things, or even indigenous practices from other countries or different places, and like shamanism, of course. So medicine pieces are normally picked from gifted people. These medicine people have seen something about this young person. They realize this person as a gifted person, and then they begin to groom them over many years. Now, this is something that many years has a different context with the natives, because there isn't really a point saying, okay, now you're ready. This has to do with their competence and their abilities and their gifts that they already have with spirituality. So, in a sense, these medicine people are professionals. They are professionals within that culture. So, for instance, okay, so I had been studying under Native American medicine people for 10 years before I ever was able to run a sweat lodge. 10 years. Now, that might seem like, well, what is there all to know? But really, I mean, there are so many, even just to the sweat lodge and the stones and the wood and the fire, the earth, the trees and everything, the way it's built and structured and everything. There are teachings to every one of these things. But also those teachings also branch off into other teachings. So in a sense, you have to be able to learn all these other things and earn all these different gifts and abilities in order to be able to run a sweat. So I think that's a little bit, can be a little bit difficult for those who are outside the culture to understand, because they see this happening. They don't see what the person went through. They don't really understand what is happening all the time. So I believe that might be part of the reason what happened in Sedona. This person believed that, oh, this isn't that hard. I can do this. But then, then many people were hurt. So, okay. So, cultural-based practices in that is to look at and consult with medicine people before a mental health or behavioral health diagnosis is made for clientele or patients who present with possible cultural symptoms that mimic mental health issues. Now, we've gone through, in 2014, we had a spiritual roundtable, which we had spiritual leaders from around the country. We had medicine people sitting all at one table. And these are many of the things that they brought up. So, schizophrenia, of course. Now, of course, they have those now that are drug-induced. And recently there was a little young baby who was diagnosed with schizophrenia. Now, this is, in a sense, a very cultural thing to be able to look at. Now, when a person, depending upon how strong their gift is, may be hard to control at first. Of course, they may be seeing things, they may be hearing things, and experiencing things that they may have never done before. They might not be ready for it, especially in this age, because many of the medicine people might not have known them back then. The tribes are kind of spread out. So, of course, long ago, culturally, they would have been in a smaller community where that would have been recognized. Now, looking at infancy, culturally, a young child, a baby, when they're born, they're already able to see spirits and hear spirits and things like that. So I'm thinking culturally that this might be the reasoning that a child or a baby was infant was diagnosed with schizophrenia, because it's not part of their culture in a sense. Those with the native culture, it would have been normal. I mean, many times we might have a baby or child within the room, but this child is also looking at something, and then they begin to laugh or giggle or smile or whatever it might be. But many times it's like we look at that and go, oh, they must see an ancestor here. So to us, it's a little bit differently. So looking at that, some things need to be looked at a little more culturally. So delirium at the end of life. To the native communities, many of the native communities, this is something that is very common. When somebody is going to pass away, they're on their bed. They see their loved ones that have passed before them. Now, many people would say, "Oh, there's something going on." They're not really there. That's not true. But with the native community, it's very common for them to see that, and they'll be speaking with them. For instance, I'll tell you a story. It's like when my father passed away. So at times my father would end up seeing this. Now, this wasn't something that we were afraid of. It wasn't something that we were concerned with, because we knew culturally that what was happening. The ancestors were there in order to wait for him at that time to be able to lead him to the other side, to where he would be going. And that's part of the reason, so that he won't get lost. He will know the way. So, but during this time, my sister was there, and she was in the room. And you ever seen one of them lamps? You can tap it, and then it kind of gets bright, turns on, and you touch it again, it gets brighter, and hit it again, and it gets even brighter. Next time you touch it, it turns off. So my sister was sitting there, and all of a sudden it was like something bumped the light, and it turned on. She looked right away and didn't see nobody there. She thought somebody might have reached around, but she kept looking, and eventually it cycled all the way through again, and then it turned back on. And she was sitting there, and she was, wow, this is really neat. And a lot of times when those kind of happen, those are spirits who have a certain amount of power, in a sense, on that side, to be able to make something happen physically. Okay, so this even goes with substance abuse, cultural considerations for those who are using them. For instance, with this, is that considering culture and drug use. Now, we look at methamphetamines. Methamphetamines have partly a cultural context to it. Now, there's this great big kind of thing going on where everybody wants to reach enlightenment or something like that, so they're taking LSD. There are even many studies going on across the world, but the way that medicine people and stuff might see this is that's a quick thing. So in a sense, it's not real. And it takes work to be able to reach those levels and to be able to stay at those levels. So having a quick fix to those is actually taking a shortcut, and you miss all that knowledge and all those kind of teachings and stuff that would have come before that. So in a sense, then when the drug wears off, they're pushed back down to where they should be. So a lot of times it has to do with evolution, in a sense, of personal evolution in spirituality or the medicine world. But also looking at, in a sense, people who have. Okay, so I used to travel with these different medicine men many years ago, and helping them to do healings and stuff all over. Well, during that time, we ran across some people who had been doing certain drugs. And one of these people had been on methamphetamine. So in getting help for this person, this medicine man did a ceremony for them, so that they would have to face the spirit of this drug. They were faced with the spirit of this drug, so they would realize and remember that all these things, even drugs that are made by man, have a spirit. Now, these things, it was not a very friendly spirit. From what that spirit had told that young person, turned that person from drugs, and they never did it again. Because then they realized every time they took that drug, who was there or what was there. Okay, so looking at integrity, psychologists seek to promote accuracy, honesty, truthfulness in the practice of psychology. In situations in which deception may be ethically justifiable to maximize benefits and minimize harm, and responsibility to correct any resulting harmful effects. Now, in a sense, this is something, looking at culture itself, is that even if somebody would go to a medicine man, the medicine man sees that this person will no longer be here in a few days. The medicine man will not tell them that. This is something because it may actually lead to that, but also it causes harm to that person as well. So it's not something that's normally done. So in consideration of this is that many practices, professionals cannot misdiagnose a client or patient, or maybe charged with malpractice. So for many natives, and from a spiritual roundtable, which I talked about earlier with the medicine people and spiritual leaders, many of them had been misdiagnosed or nearly misdiagnosed with mental health disorders. That was because at that time, again, is when they were younger, is that when these gifts, in a sense, opened up, that door became wide open. And if these gifts are very strong, then in a sense, these energies, in a sense, that are coming from that boost this person to grow faster and faster, be able to hold those kind of energies and those gifts. But the person is not always ready for it. So they kind of need to be able to learn to control that. So in a sense, looking at things and see if we can get your comments, is what would be a good way of correcting a misdiagnosis once it has been done? Nobody? Okay. Looks like you have one person typing at least. Okay. Heather, is it Leader? Psychological testing, in-depth discussion with client about their cultural norms. I am not certain, but I have thought about this for many years. Okay. Now, many times, once a diagnosis has been set, doctors, psychiatrists, different professionals are not willing to be able to say, I made a mistake. Because if they do so, that would be malpractice. Now, I don't think that there should actually be anything done with this person. To me, I think it would be good if they could say, okay, I didn't understand this at the time, and we see more and more of it coming now as culture is beginning to be able to look at within the Native community a little bit differently, or within indigenous cultures. This is not something that had always been done. I think that there may need to be a consideration of changing this in a sense so it's easier for that likelihood of somebody coming forward and said, I may have made a mistake. I don't believe it's their fault. I mean, culture, in a sense, is a little bit different. It takes many years to be able to understand these things. But considering this is for the help of clients or patients, I really think that it would be better if cases like this, there was not really anything done with with a doctors, psychiatrists, mental health people, or whatever like that. I believe it would be better to let that diagnosis go away for them and to be able to move on from there. But one thing that came about with the spiritual leaders is that when a diagnosis comes about, is that they should refer to medicine people, spiritual leaders within the tribe that person came from, to be able to look at this a little bit different. Let the medicine people be able to assess this person, whether that person is gifted or if those things are actually some kind of mental health thing. Okay, so go a little bit further into, again, the overview of the 42 CFR. So remember, it applies only to federally assisted programs. Now that is the new part of which that, the changes came about. Remembering that tribes are federally assisted. Many of the treatment centers and stuff, they get federal monies for those. So those do come into play. With the changes that's been made, one thing that I wanted to bring about this was that, remembering, even if an agency has a qualified service organization agreement, a patient can revoke consent to one or more parties at any time. Remember, this is the client's right. Now, of course, we might have clients who don't even want to sign a consent form at all to anyone. One thing that comes from my standpoint in the past was that, so if a person was court ordered, or if they had a probation officer, they did not want to sign a consent form. Normally what I did was I said, okay, we don't have to sign a consent form, but I have a question for you. If your probation officer calls or the court calls, I can't even let them know whether I know you or not within this treatment center. I can't give them any information. And then I said, and that will lead you to get in trouble because it'll look like you're not even attending treatment. So that was one way I was able to help to be able to get the clients to be able to at least sign a consent form to speak to the probation officer or something like that. That helps to keep them out of trouble as well. So a lot of times in these, we also need to educate the clients about consent forms and everything like that. I mean, it says we're supposed to, and help them to understand that. So it's good practice to be able to do so. Now, with the exceptions of the 42 CFR, is that remembering that if a crime has been committed on the premises, they pose an immediate threat to themselves or others, or that they did something with child abuse. Remembering, some people will think, okay, this is only federal, so it doesn't go to state. Well, there are some laws about that. One is the 42 USC. Now, that came about, I think, from a military post, is that something like that came about. So it was kind of brought into court, and they came up with this law. Now, it's kind of different because if you're looking at many of the ethics, many of these different laws, What's really sad is because many of these cases have come about because something in the past was done. So it's something we need to be able to consider. It's like wrongdoing in a sense in these fields. It also does bring about more changes. So remember, it's like crime on the premises. If they pose harm to themselves, or such as suicide, or if they're going to go hurt somebody, suspected child abuse. So those are things that can be actually there has to report to the local authorities. Now these are also things that should be brought up pretty much in every before every session even begins, so the client is aware of those. So privacy laws and ethical considerations with this part is that there's a potential exists for ethical dilemmas, of course. Now, when Robert had done this last week, I just wanted to bring this back up again, is when it's possible, always consult your organization's leadership on how to respond. Now, if you have a supervisor, of course, let them know if you're not aware of this. Remembering though, if your supervisor is from another field, they might not understand the 42 CFR. So sometimes being able to speak to other professionals may be helpful. Of course, you can't give them the name or anything like that, but to be able to have a little idea of what to do next. Okay, so non-discrimination. Now, part of this I wanted to bring up was that stigma is now considered discrimination. Now, that's kind of a new concept in a sense that came out recently, but remembering stigma is discrimination. So, other code of ethics, memory different states. Two of the largest ones that hold certification process is the ICNRC and NADAC for substance abuse. So rules may be phrased differently. Many of these different code of ethics are phrased differently, but are built on similar principles. Remembering also, if you work with tribes, they may also have their own code of ethics. But remembering, when you're dealing with more than one code of ethics, go by the highest standards. Now, if one says you can only do this upon this, if one says you have to wait so many years or whatever it is, then you need to be able to pick the one that's most strict. That'll help keep you out of trouble. So, in looking at that is the overriding rules of ethics. Remember, is to keep the client alive. So, if they pose a danger from themselves or others, plan to do harm. So you have a duty to warn in a sense. So, but also with this is the mandatory reporting laws. So, Principle 8 with confidentiality. Now, the reason I bring this part up again, from what Bob had spoken to you about, is that with confidentiality, there comes into a play with this. What if your tribal council members want to see either a client or former client's records or information? Now, considering your legal and ethical obligations to the client, what are your choices? Well, one thing you could do is to take the 42 CFR, just as you would with a judge or county attorney if they're not aware of this, is to let them read the book themselves or to look at that section. Sometimes before, the judges and stuff weren't always aware of this either. So this is information to be able to help them. And remember, we have a duty to be able to help our clients to be able to keep from harm, your confidentiality and such like that. So, but one other thing you could probably do is to ask the tribal council to consider, if this was you or one of you or your family members, what would you want done? How would you want this handled? Because remember, a lot of times tribal councils change over time and they could do the same thing. But remember, this is a federal law. Okay, so obtain the client's agreement in areas like to affect the client's participation, not engage in professional relationships with clients. This is something a little bit difficult. With Native communities, remember, family systems are different. The way they approach those things are different. Tribal community and those from the outside are a little bit different. You can go to a tribal substance treatment center somewhere else and nobody will know you. But in a tribe, many people do. And many of these people may be related. So at all costs, try to find somebody within the agencies that is not related to others. Sometimes you won't even be able to do that, but you have to be able to find some way of meeting those requirements. That's why it's always kind of good to be able to have natives and non-natives. That's my point of view. Or those from another tribal members from another tribe. So ethical dilemmas. So I think we've gone through this last time. I think Robert. I'm sorry. Police officer arrives at your facility late at night with a search warrant and demands to let you see him or her, let him or her in, and the person says, "I know you're here." Well, that's something you will not be able to do. For one reason, it's only a search warrant. You need a search warrant and a subpoena. One thing about it is, if this officer was outside and seen the person come in, that might also be violation of confidentiality. So, example 6. What do you do? A client in your facility has seizures and requires medical attention, but has signed no consent forms. Remember, this is also one of those things where it's a little bit different. Remember to keep your client alive. Under medical emergencies, those things are normally authorized. So, if a police wants to know if someone is there in your facility, and you know the person is not there, you can tell that police that. But that's only if the person is not a client. Remember, with confidentiality, you cannot let them know whether if you know them or not. But this also helps to keep, that you are working with the police and the courts and stuff like that. You're not just trying to hide everything and just throwing these laws, in a sense, at them. Sometimes it's better to be able to let them know that you're willing to work with them. So, on another point is, what constitutes evidence-based practices? What factors constitute cultural competence? Now, we've gone over some of these things, but these are questions to probably kind of think about for future. Evidence-based practices. Remember, it's an integration of best research evidence, clinical expertise, and patient values. Now, patient values, remember, from a Native community is going to be a little bit different. There's not a whole lot of places where natives have actually, they've gathered a lot of reporting from native to be able to do that. Now, in this part where it says that there has not been any reporting of American Indian Alaska Native community perspective on how to achieve widespread implementation. It's because many times the tribes are very different. Their belief systems are very different. There isn't going to be able to be, a very easy way and be able to incorporate all the different cultures into one thing. So cultural competent is culturally competent when one person, the culture, has knowledge and skills of a particular culture to deliver effective intervention to members of that culture. But remember, cultural competence, if you're not from that community, it can take years to be able to understand about from a native community and all the practices, the knowledge, and everything else that needed to be able to assist them. So, can we answer any of your questions? I think we're just about at the end.
While we're waiting for questions to come in, I'll just mention that we will be sending out follow-up emails to everyone who attended and also everyone who registered. So you'll get a link to the recording of this webinar in case you want to view it again or share it with colleagues. You'll also get redirected as we close out to our survey, but the link for that will also be in the email, and CEU forms will be included in that as well.
Okay, so do I have suggestions for locating trustworthy medicine people? One thing I would do was to, it's like kind of like window shopping in a sense, is be able to find people that you trust who utilize certain medicine peoples. That'll be able to help you get an idea of how people think about this person and their abilities, what type of healing and stuff their strengths are. Sometimes certain medicine people will be very strong in one area while others may be stronger in another area. I hope that answered your question.
There is a question, it looks like it got just sent to presenters, so not everyone was able to see it, but someone was asking, do you have a suggestion for locating trustworthy medicine people?
Yes, I just answered that.
Oh, I'm sorry. I I was trying to read through all the questions and wanted to make sure. Sorry, I missed your answer to that one.
Well, if there's no more questions, I thank you all for listening in today.
Yeah, thank you so much, Sean, for sharing your experience and expertise with us. And with that, we'll finish up for today. And thanks again for joining us, and we hope you join us again next time.